Okay. All right. I think we are on the second slide, which is fine.
Sir, now you can changing from your side, sir.
I can change. Okay, great.
Yes, yes.
Okay, I think
You
we
can
go
change.
quickly down. All right. We
Yes,
lost
sir.
2 minutes. Sorry about that. Okay. This
You can
is
start, sir.
sponsored by MSD. So you see the usual disclaimer. So we discussed this problem of pandemic and management of hyperglycemia. I think this has been much talked about topic and very much in the media as well, and a lot of our meetings. But I'll summarize some of these aspects quickly with some of the experiences which I have had controlling hyperglycemia in my patients during this 1.5 or 2 years of time. So one thing is doctors are not easily approachable, lack of connection with physicians. And then many patients don't accept teleconsultation, which can be one way of treating this hyperglycemia. Quite a few of my patients are waiting until we started in-person clinic. So there's some who cannot handle this, something like I could not share the screen now, something like that happens to them all the time. And of course, you see exercise are not regular. Food, early on, I found sugars were dropping in during COVID really, because food availability was really scarce. But later on, as things improved, food supply improved, yeah, I find that hyperglycemia started increasing in all my patients. And overall, I've done teleconsultations about close to 4,500 during COVID period. And each day 6 to 8 and 6 hours a day, by the way. See, not in 2 hours finish some 6 or 8 patients or 10 patients. And we have done that. And we realized that slowly they started gaining weight and the food availability getting better. Economic challenges were there. People lost their earnings. They could not adhere to the program. And there was non-availability of strips, especially I've seen the medications were available. The strips availability was bad. And therefore, people could not monitor. See, now, how does uncontrolled diabetes impact COVID-19? And of course, COVID-19 infection increases insulin resistance. Insulin resistance obviously causes poor insulin response and overall leads to relative insulin deficiency. So on the left side, you see all those, and from there ensues all the effects of hyperglycemia, which I don't want to describe for you. But I want to emphasize is that even a type 2 diabetic can be in DKA, in diabetic ketoacidosis, in a situation like this, infection or stress. Remember that we always sometimes say that diabetic DKA occurs only in type 1 diabetics. A type 2 diabetic with relative insulin deficiency in states like this can go into ketoacidosis. So it's better to remember that this is possible. And many of them, those are elderly who suffered more with COVID infection, they will go into a hyperosmolar state. And when being admitted to COVID ward, their sugars were high. At that time, the one major problem was communication. Communication with the COVID team. Like in Jaslok Hospital, we had a good COVID ward, and our COVID team was trying to do a great job. However, early part, when we were not involved, even online, you see, we found that patients being discharged with 600 to 700 blood sugar, most of them. And even mild to moderate COVID being discharged, the sugars, especially if steroids were given, it will be 600 to 700, especially in moderate one. You see where steroids were given for some reason, for a valid reason, and hyperosmolar state would occur. And then we had to handle that online and combat that hyperosmolar state. So these are the possibilities. You see, hypoglycemia, interestingly, also can impact the outcomes. And therefore, use of hypoglycemic agents will have to be extremely cautious in these emergencies. And although remember that insulin is the mainstay of treatment, and therefore you'll have to use it extremely cautiously. And hypo both can impair the immune system and thereby increase the severity of the COVID infection and the poorer outcomes. But hypoglycemia impacting immunity and affecting outcomes, sometimes we don't realize. So we have to be extremely cautious in not producing a bad episode of hypoglycemia in these people. So between bad hypoglycemia maybe and bad hyperglycemia, we have to steer the course, which we do in most emergency situations. And this is one of those. And I think those who handle emergencies, we will very quickly, they could get a handle over this situation. Then very importantly, what kind of blood glucose you should target. And you know that we have gone through an era where those very famous studies of Vandenberg, etc., were there, which were advocating a much stricter control in the intensive care unit as well as people with the other emergencies. But this nice sugar study, which appeared in NEJM, you see, uh, uh, about I think 15 years ago, see, nice sugar study showed that instead of having the blood glucose values try to target and bring down to something like 80 to 120 or something like that, it is really more injurious and it causes bad outcomes. Frankly, what you should aim at is something like 140 to 180, 140 to 180. See, and maybe even 120, but don't try to go below 120 because hypoglycemia is real risk. And remember that 70 is hypoglycemia itself. Many of us don't realize, we only think of 40 as hypoglycemia. 70, 68 exactly is where the counter-regulatory responses start. So you should not go there. So when you talk of 80 by 80, 120, you're really endangering patient's life. Now, teleconsultations were very much appreciated during that period. And many of us have done that. And I'm sure many of you have done even larger numbers, volumes. And you see, and one, of course, you talk on the phone, and secondly, face-to-face, you can see on the video. So what is really important is diabetes self-management. And they're already, if you had educated your patients, those are already taking insulin, you educated them, there's less problem. But many of them you have to educate online, self-management. And new ones, which we had to start insulin on some new ones, we had to really take a course to a nice video showing how to inject insulin. And frankly, most of them were able to do it. Really, nobody had to go at home because there were not many people available to go at home and demonstrate. And then they learned from that video and they started insulin successfully. They started measuring glucoses for the first time. We started them by again showing the demonstration online or just sending a video of again how to do that. So I think we should have those with us, so very quickly you can send those to the patient and they can learn from that, you see. And of course, you see, you of course use the proper anti-diabetic agents that we discuss as we go along. So face-to-face also is sometimes important, because you may like to see some signs. It is really possible to see some very important signs. The most important is in general seeing whether the patient is very sick, because sometimes while talking to the patient, you don't realize whether this patient really needs hospitalization. Sometimes the relatives can transfer that anxiety and you understand, you immediately start perceiving that this is a bad problem. I must take this patient to the hospital, or advise that I will not treat you on outpatient basis, you see. And this is important. And of course, the oxygen saturation, you keep asking them all the time. This is very important. It becomes very important to monitor that. And then when you see a patient, sometimes on the video, you can appreciate that the patient really appears very ill and maybe dehydrated and really sunken low, and therefore has to go into the hospital and get hydrated and maybe properly treated. So this is important. So of course, a lot of education is possible through this. As a matter of fact, education has become actually better during the COVID period between we physicians also, between all experts, between all technical people. I hope between politicians also, education has spread because of telemedicine, also because of teleconsultation with each other. So I think we can really teach patients quite well on this. And I think this is very important to look at all their comorbidities, teach them about basic skills of, either insulin injection, the blood sugar testing, and hypoglycemia has to be taught if you are prescribing insulin first time on them. And earlier they have not faced this problem. You must talk about hypoglycemia and sick day routine. You should be extremely familiar. Some of us who have 2 to 3 educators, sometimes 4 educators employed in the clinic, you see all the time, most of our old patients were fully trained on all these aspects. In fact, these aspects are not only taught to the patient, but there is a clear record maintained, a signature of the educator who has conducted this basic survival skill to the patient. And that is, therefore, we found them very easy to handle these patients during COVID. But newer ones, we have to do the education part itself and take it further from there. And of course, we were still quite successful in controlling their diabetes very well. And those who were discharged from the hospitals with bad hyperglycemia, also we were able to control. But the idea was to really, be in close touch with them and communicate mainly on the emails and on the phones, really. And a clear period of 6 or 8 hours where we will sit down and answer all these calls and help our patients. So this is why face-to-face is necessary in order to elicit some science, some more science and look at the general aspect, which I told you. I won't go into details of this slide, but remember that, you see, you can easily see edema. Seeing the face, you sometimes realize, what is happening to the patient. So you can see a goiter, you can see leg with edema. In diabetic foot, you can see on a video lot of things that, I've treated some very bad diabetic foot infections during COVID period and very successful. In fact, most of them ended not beyond a amputation of a toe, frankly. And as a matter of fact, below knee, we don't remember for the last 1 decade we have done any below knee in our Jaslok hospital, because we are able to vascularize people, and most of them are due to neuropathic ulcers. So remember that you can do a lot in the diabetic foot and follow them very nicely with your teleconsultation and treat them with antibiotics and, of course, a good control of diabetes. History taking, I would not like to go into details of that. This is something very basic we learn. However, I must say that those who are oriented to good history taking can do very successful teleconsultation. Those are very much trained to elicit a lot of science and very, very exotic science with 3 different techniques. They are quite absurd, they cannot apply telemedicine very well, And those overall all trained in USA they are very good history takers, and overall trained somewhere else, there are some blind spots, and history taking is not as good. The most important thing missing there is the review of systems, where you inquire questions, 3 to 4 questions about each vital system, whether the patient has those symptoms. Like, for example, cardiovascular system, when you review, you'll ask whether you have dyspnea on exertion, whether you have edema, whether you have cough, are you breathless at rest. So these direct questions, what is called in UK, textbooks, system review is lacking. And I think that if you introduce, you can do very successful teleconsultation, because you more or less have diagnosed everything by talking to the patient. And then you really can see a few signs on the video, and you can go ahead and do a good job. So this is very important. So telemedicine examination, what do? You see? And for the foot especially is very helpful in the diabetic. And of course, you can see patient's anxiety, patient's expressions. That also tells you what is happening to that person as a human being, which is also very important for you to take some decisions. You see, and I think you can elicit some signs. You see, now drugs and insulin, sometimes you can remove the errors. You'll see on video, for example, you can tell the patient to show the drug, and sometimes you realize the different strength. You see, for somebody taking thyroxine, the chemistry pass on a different strength or wrong. So all that can be done. You see,
sorry to interrupt you, sir.
You want me to operate?
Yes, sir. I'm giving the right, sir.
You will do it?
No, I'm giving you right, sir.
Okay.
Yes, sir. You can now change from your side, sir.
Okay. So we go fast. Telemedicine. It's not changing. Okay. All right. Yeah. We were somewhere here. Okay. See, medications, I see diet, exercise, we will talk about. And I think patients are already educated, have no problem. You see, medications, frequency of monitoring all varies. In those who are very sick, badly hyperglycemic, we advise them to monitor about 3 times a day, not 6. Frankly, we have a strategy of covering 6 samples in either 2 days or 3 days or even 6 days. So 1 sample a day, 2 a day, 3 a day, 4 a day, like that. And I think that works very well, because the 6 times a day in some very mild patients may be unnecessary. See, and of course, patients should know about hypoglycemia very well. You see, in India, what happened is, you see, pre-existing poor glycemic control, because at the moment we achieve A1C goals only about 25 to 40%. In best clinics is 40%. In average clinics is 25% of people controlled. So majority of these patients undergoing COVID are already pre-existing. They have a bad hyperglycemia, and therefore outcomes can be quite bad. And I think you have to look at the medication. Here, the most important thing I wanted to see at the bottom, the two boxes, and there you see that main important most thing is in mild and patients who are ambulatory, you can almost use any drug. You see that you like cautiously, the way whatever your algorithm shows. But hospitalized, moderate disease and severe disease, you see at the bottom, the drugs that to be used extremely cautiously and not to be used as far as possible are TZDs. Because they can cause edema, that is severe water accumulation, and SGLT2 inhibitors, which can cause sodium depletion and can cause problems, and can cause also very mild non hyperglycemic ketosis or ketoacidosis, normoglycemic ketoacidosis. So that is possible in all emergencies. Sulfonylureas and T also, again, very cautiously, because often you are using insulin, and then to use a sulfonylurea, two hypoglycemic agents, you can get bad hypoglycemia. So I think this is otherwise, frankly, all the drugs can be used cautiously, but moderately severe and severe patients, you have to be very careful about some of these drugs that we talked about. See, in some pregnant people during COVID also, you have to treat pregnant women. And again, of course, the principles of treatment are same. I don't think I had delivered anybody during the COVID period. Maybe that delivery boom probably came after COVID. See, and hyperglycemia at admission is very important. Now, you see, any person getting in, now this is a newer aspect of hyperglycemia in COVID. Any person, for that matter, in any emergency patient gets admitted, which includes COVID, sometimes is not a known diabetic, but blood sugar should be done. It is considered routine now. If blood sugar is done and it is found to be high, you see, hyperglycemia at admission with known diabetic, unknown diabetic, both are very important. And you see, unknown one, you have to be very careful, because first time you are diagnosing hyperglycemia can be very bad. And younger ones can be in DKA. As a matter of fact, mode of presentation of type 1 often is DKA, you see, and there the mortality is very high, you see. So I think newly discovered diabetic also, and hyperglycemia of any region there, known or unknown diabetic, I think the prognosis is altered, prognosis changes. So some of the papers that we have are along these lines during the COVID period, showing the importance of hyperglycemia in general there. And there are some of these people have what we call stress hyperglycemia. Subsequently, they are all right, but they are hyperglycemic with COVID, which also is important. And to the extent that sometimes it will require treatment. A1C assay will give you some clue whether person was diabetic previously or just has the hyperglycemic spike because of some problem, because of the bad infection and whatever other changes take place with the infection, insulin resistance, etc. So A1C may give you a clue that is already a pre-existing diabetic for a while, but undiagnosed, which you know that for every diagnosed diabetic, the one undiagnosed diabetic in most part of the world, and certainly in India. See, hyperglycemia during hospital stay, of course, you can manage very well, and there are different steps. You see, with simpler management to the very complicated management. Government of India issued some nice guidelines for this, and I think they may be interesting to see. There is step-by escalation of what kind of treatment you give for hyperglycemia, from simple monitoring and simple insulin doses subcutaneously to starting, you see multiple dose basal bolus therapy, and of course, insulin by infusion. In bad emergencies, very serious patients, by infusion is excellent way. Only two practical points there. Infusion, what you use, you see, first 5 ml, you should really flush out the whole system, then only starts working immediately. Otherwise, it takes about 1 or 2 hours to even start working. You see, that is very important. And of course, you have to have frequent testing and changing the rate. Very, very important. You see, so I think you escalate your treatment as it is required. And when sugar is high, obviously, you will institute insulin therapy. In this situation, I don't think you will take recourse to any other drug. Only if you see at the oral agent, the safest one in this situation is not even metformin, you're slightly worried, especially if they're dehydrated, slightly low blood pressure. There is anoxia, mild to moderate, severe anoxia, then metformin is a dangerous drug as well. So frankly, it's amazing that the safest drug it appears in this situation and in many emergencies we do is using a DPP4 inhibitor. DPP4 inhibitor. So side effects wise, their profile is one of the most favorable profile of any oral drugs that we use in diabetology. So I think this is very important point to make. And of course, the sitagliptin has been used in many such situations without any problem. You see, so I think undiagnosed diabetes or stress hyperglycemia, stress hyperglycemia also, frankly, the glycated hemoglobin will be slightly high as well. You see, and no low risk individual, high risk individuals will treat differently. See, monitoring is less frequently in low risk individual, very close monitoring in others. So I think the drug that you use, contraindication mainly is SGLT2 inhibitor and even metformin in many situations. These are the ACE drugs in diabetes in ambulatory patients. And these are exactly the drugs to be almost stopped in any seriously ill patients, which includes a patient with COVID infection. So most of the time, except very mild emergency, you can continue small dose of metformin or SGLT2 inhibitor, no, because this is overall contraindicated. So this is very important. The rest is, I think, simple. Sulfonylurea, you've heard about hypoglycemia, pyrethroid, about edema. So frankly, you narrow down very much to a DPP4 inhibitor. This is very important, no, and insulin. This might be the safest combination in these people. See, and of course, again, use of anti-diabetic agents. I don't want to go into details. I've given you basic principles of what we use and why we use. How you use insulin, I think, we can't take because we already lost 5-7 minutes in some technical problems. But you start with a low dose. Insulin, somebody who has never received insulin is very cautious with the first dose. Don't ever give a big slug because response is very brisk to insulin because there's no antibodies. After a couple of days, there's some mild antibodies, even with the best analogs that you use, and therefore they buffer and you don't get bad hypo. But initially, don't use a large bolus of dose because sugar is very high, so give a big slug and you get very bad hypoglycemia. So be very careful in insulin naive patients. See, and also what doses you start and all, Steroids, when do you use this? This is not the platform to say that. But if they are used, your job becomes difficult and you will have to really institute in the major bolus insulin therapy with probably a DPP4 inhibitor and or a insulin infusion. See, new onset diabetes, another focus. Somebody not known, as I told you, undiagnosed. So there you are not prepared. So the person is diagnosed very late that there is a problem of sugar as well. So it's very unfortunate situation to discover diabetes because you have to start the whole treatment then. And obviously they can be in ketoacidosis, even type 2 can be in ketoacidosis, as I told you right to begin with. You see, so new onset hyperglycemia, why does it occur during COVID? Of course, it can occur in any infection. There is always a family background of type 2 diabetes, though in many of these people, if you take the history carefully, and of course, there is a stress, there are cytokines, and there is corticosteroid treatment going on. All that, they all lead towards bad hyperglycemia, as I told you, and that all COVID units where sometimes the diabetologist is not visiting personally should really be online, connected diabetology morning and evening and take instructions. That's the only way to control. In fact, we made that in Jaslo, and thereafter the diabetes was beautifully controlled in our COVID wards. Initially, they thought that it was difficult to do these calls and difficult to connect, but then we made it possible, and then things happen. You see, and of course, COVID aggravates hyperglycemia. Hyperglycemia aggravates COVID infection. So there is a very unholy relationship between these two, and this has been shown in a couple of papers. This unholy relationship and how you see in diabetes, you see our ACE inhibitor, ACE2 receptor is very, very important for us for the RAS system, and COVID virus is very intimately, is connected with this receptor and is the entry point. However, in spite of this biochemical knowledge, there has been no adverse effect shown of the DPP4 inhibitors used in the COVID infection. This is very important. That clinically there is absolutely no correlation. And as a matter of fact, it is also surmised in some papers that it will be beneficial to have this going. Or ACE inhibitors also can be continued. Patients who are well stabilized on them, you should not discontinue. So these two drugs are they were questioned at one point, but it's clear now that they can continue to be used. You see, I think newly diagnosed diabetes may have higher mortality because they're diagnosed late. They may come in a very perilous state and therefore they high mortality. So this is a very big subject, the newly discovered diabetes in these emergencies, and they have to be handled extremely carefully. And diagnosis has to be made. As a matter of fact, as we said, when some of our colleagues have shown that doing a blood glucose is the fifth vital sign, we say, besides pulse, blood pressure, etc. So this is very important. If you do that, you won't miss diabetes. In children, you can miss easily. Unconscious children, very, very regrettably, there's some places when we were called to see later on, diabetes are diagnosed after CSF, the sugar was very high, which is very deplorable. Which doesn't happen now, you see, but this has happened earlier. We have seen being diagnosed with a very wrong way of diagnosis, you see. So I think overall, management of hyperglycemia, I'll skip some of this, was all routine. So thank you very much. I'm sorry to overspend about 5-10 minutes because of some problems. Thank you very much for your patience.